Hi, I'm Alexandra Kilgore. I'm the Associate Director of the Neurogastroenterology and Motility program, also known as NGM program.
And my name is Jaime Belkind-Gerson. I'm the Director of our NGM program at the Digestive Health Institute at Children's Hospital, Colorado. Our NGM program treats children of all ages, from infancy into young adulthood. We specialize in a variety of neurodigestive conditions, including but not limited to achalasia, gastroparesis, cyclic vomiting syndrome, Hirschsprung's disease, pelvic outlet disorders related to constipation, amongst others. Thus, in general, we specialize of disorders of intestinal motility and sensory function. In our practice, however, about 70% of our patients have lower GI, in other words, colon problems, so today we'll concentrate on these.
We treat these kids with a multidisciplinary approach. Our team includes the pediatric neurogastroenterologist, the child psychologist, pelvic floor physical therapist, occupational therapist, and a registered dietitian. At times, we also work with a pediatric pharmacist, urology, and the colorectal team, as well as neurosurgery and general pediatric surgery. We work together to develop individualized plans for our patients to address their conditions in both the present and in the future.
In particular, we're very aggressive about pelvic floor improvement, as we see many children with pelvic outlet disorders and abdominopelvic dyssynergia, and thus we use a combination of medical, behavioral, and biomechanical modification techniques. In addition to a careful history and physical exam, we often use anorectal manometry, colonic transit studies, colon transit marker studies, and spinal cord MRI to help confirm the diagnosis. At times, we may also use colonic manometry or even MRI difficography. Medical treatments include the use of osmotic and stimulant laxatives both orally and rectally, enemas and Botox injection into the internal anal sphincter. Behavioral modifications are addressed with the help of our child psychologist and occupational therapists to improve on a patient's stool withholdings and toilet sitting refusal. Finally, the biomechanics are addressed by our pelvic floor physical therapist using pelvic PT and biofeedback.
The combined approach is very successful, but at times, a few patients need a surgical approach in their treatment of their constipation and/or fecal incontinence. Working closely with our pediatric surgeons, we may recommend the surgical placement of an antegrade cecal or appendiceal enema device for daily colonic flushes. In rare and difficult cases, we may determine the best treatment option is the placement of an ileostomy or rectosigmoid resection for massively dilated distal colons with very poor motility. We are excited to find that the majority of patients treated with anterograde enemas or fecal diversion can eventually accomplish normal defecation without the use of enemas and/or are able to reestablish colonic fecal flow.
In the future, we hope to have better treatments, so we're very involved in clinical and basic research studies in our field. For the former, our studies include external electrical nerve stimulation, ultrasound-directed botulinum toxin installation into the GI tract and its associated sphincters, and the use of newer motility agents such as procalipride and linaclotide. Our basic studies in the lab are focused on enteric neural injury and regeneration, as well as better understanding of the brain-gut microbiome axis.
Thank you for your attention. We're here if you need us. Feel free to contact us with any questions.